Good morning, everyone. Thank you very much for the cordial invitation. It is a pleasure for me to be present at this great talk about Horizon 2100. My name is Alvaro Tapia. I am a professor at the Faculty of Medicine of the Catholic University of Cuenca. My professorship, which he taught here, is the part of medical semenology of specialty and also the part of histology. Within my preparation, the health part. I have administration and management in health services, so precisely within my work there is a lot the part of seeing the future, of seeing where the hospital part is going, where we will have to focus, and that is exactly what has me very studious. He has me very within the curiosity of being able to understand what is going to happen. Within this we must start with a phrase. This sentence is older than 2000. It's a phrase that I love because it just speaks about what the vision of the future was like. Before the 2000, what do they tell us? The surgeries will be performed without a scalpel and without blood. Technology will revolutionize the way we treat diseases. Unknown author, before the 2000 years. This phrase here does not mean that everything we have always been trying to think about a future in health, how it will work. Now it is already a reality of the present that we are having, in which we interact with artificial intelligence, with robotics. It seems incredible to me. Let's analyze the future a little bit. That I think we could handle it. Let's start with a very important area. The consultation and the online consultation. The evolution of medical consultations is from face-to-face to virtual. I think that the part of the pandemic helped us a lot and boosted us a lot in this. If we have something to thank the pandemic for, it's this TV consultation thing. I think it had its base and of course its growth throughout the pandemic. We have seen that the best that the consultation, the online consultation, can give us is greater accessibility to rural parts. It's amazing what we can do. I live in a country that is called Ecuador, which we can cross in less than 12 hours from north to south by road, but from this west it will take us much longer, because here we have just the part especially of the Amazon, the jungle part, the part with more limited access. It is important that we keep in mind that the online consultation is going to support us for access to those places. For rural areas, they are currently managing it a lot in the city, but in the future, I think that this here is going to expand to all those places, to all that rural part where we need. What can we do with this online consultation? How will you support us in the integration of emerging technologies? Which ones? Artificial intelligence, virtual reality. Why haven't I put the robotic part here? Because that's something that's already there. It is something that we have rather evolved a lot, but what is in emerging technology is artificial intelligence, virtual reality. What else do we have? The OME always asks us to have a greater control of chronic diseases. We know the chronic diseases like the cardiac part, the respiratory part, the cancer part. All these diseases need treatment. Timely follow-up is usually quimestral. Sometimes we do it semi-annually. There are emergencies that we need to do on a monthly basis. And it is timely. Very timely, and the online consultation can give us that type of continuous attention that we need everywhere. I always set an example and say, let's think that we are an inhabitant of our Ecuadorian East. We have to move so that the doctor can see us later in some city in the Sierra, the city of Cuenca. 1. We have to first wait for him to give us a shift, to give us an appointment, then move by land, maybe 12-13 hours to get to the consultation. Wait for the doctor to arrive, hope that you have not had any medical emergency, and that you can attend to them right away. After that I have to wait for a turn to have the supplementary exams taken. What if I just had to take the time to schedule an appointment that I could make in less than an hour? The doctor is going to be there, the doctor is going to be present, the doctor is going to provide me, he is going to tell me the complementary examinations that I need. And if it had the accessibility that we're going to see later on from those exams, that would be amazing. Medical care would be as timely as possible, and for these chronic diseases, care would really be the difference between life and death, which is what we currently have. If we already have booths designed, especially in North America, we have seen that we have booths that are designed to be able to make an online consultation already, in which we have all the part of the sensors. To measure all the basic vital signs, we have to measure pressure, respiration, oxygenation. We already have that currently. I think a very promising future is going to be that we can move forward. And I see an interaction with the virtual realities part, with the virtuality part, in which I arrive, maybe put on special glasses. I can enter a doctor's office in which the doctor is not there, but I can lie down on a stretcher. I wouldn't even need to put on a meter or the sensor. Only with what I have there on a stretcher will absolutely all my vital signs be checked. It could interact with the doctor. The doctor will be able to ask me inside that same stretcher to have an image performed. The whole future. This is the vision that we have in this consideration of the online consultation. What else do we have? Lab tests, that's from the future. That is a proper treatment that we are going to have. Here I have regressed a little bit and I think it helped us a lot here. Such tests as genetic sequencing. I think it was what allows us to have a more promising future. Everyone now has access to this genetic sequencing, if we want it and if we have the economic support. I think that's one of the limitations now. Currently a genetic sequencing exam should be for $50,000, $60,000, speaking of here in our country. That should be the cost that it should have, but starting from there we have exams that are going to support us and that are going to be. I think it's our present and it's going to be our most promising future. Because thanks to these exams we are going to have the real future of health, to be a personalized health, a health in which it is for each specific one. What I always say with first and last name. The exam we are going to do is with the patient's first and last name. I always set the example and I like to place it in this instance as well. What exam do we have? Nutrigenetics. What was going on a long time ago, we went to the nutritionist did the exams, a biometrics, saw how they were so triglycerides, as is cholesterol. And he was saying, you know that these exams are like this, we're going to send this diet. You know, carbohydrates are going to make us gain weight, glucose. But what would be the difference? If the nutritionist sends us to do a nutrigenetics exam in which part of the genetic sequencing will indicate us. If I'm going to have or am susceptible to the fact that carbohydrates are what make me fat, sugars because my diet has to be a little more balanced in proteins, I have to decrease carbohydrates the same case, but not glucose. I think that's already making the present, but it's going to be the future. And let's complement it now with what? With the pharmacogenetic examination. We have already relied on studies that tell us, yes, you know what, this study in this kind of people have seen that this antibiotic, this analgesic is better. The typical example I do, paracetamol and ibuprofen. With this test, we can know specifically how our body is going to interact and in what way it acts better to be able to receive a medication with name and surname with the patient's name, which is the one who is with us. Who is going to support us in nanotechnology and automation? The laboratory, computerized exams, nanotechnology and automation are what will fully support us in the future. Continuing with these complementary examinations, we have the diagnostic by imaging. There I want to share with you a phrase, which in the readings I have done I really liked. What is it that he tells us? Doctors depend on our knowledge and experience, limited by our geographical location. While artificial intelligence has a large database and fast processing for more global diagnostics. What is going to help us with artificial intelligence? A reduction of human errors, caused by fatigue. A subjectivity to the diagnoses we may have. It's going to be a diagnosis, which is going to have incredible speed. I always say that image processing is when you just do the medical part, visualize the images, and in your mind the library to which we had access, to the books with which we were educated, to the places where we had the education, opens up. With the different artificial intelligence algorithms, we will be able to process and analyze images in an immediate way, and of places that we have never been able to think of. I tell you, a lot of the training of our doctors here, of our faculty has been within our American continent. There have been exceptions in those who go to the European continent, but very rarely perhaps we have gone to the part of Africa, to the part of Australia. But precisely, with everything that we nourish this artificial intelligence, it will help us for the part, in this specific case of images, to perform a much more appropriate processing. What is the next step? Surgery. robotic surgery and telesurgery. The function of robotics, which is what we already have, and what's more, we have made a lot of progress in robotics. And artificial intelligence will enable high-precision telesurgery. What do we gain from this? That surgeons will be able to perform procedures from remote locations using surgical robots, which will expand access to specialized medical care, but on a global level. I have told many patients what happens if I propose an appendectomy. I have the doctor here who is going to perform the appendectomy, and I have a robot that can also do the same procedure. Many of the patients have told me, you know what? I prefer the doctor to see me. The doctor will be there. He's gonna be able to see me. He's going to be able to see any setback. What if we do the comparison? And the robot is the one that's going to give him a pressure of 99.9%, and the doctor is going to give a pressure of 90 or 95% accuracy of the procedure, and there I can increase something more. What if I tell you that the doctor is going to be supervising, but the one who is going to manage the equipment via telematics is going to be the best surgeon in Europe? The one who is going to interact with this robot has a 99.9% success rate in the surgery process. He is going to be handled by one of the best surgeons in Europe. It changes completely. In many of the cases there is talk about costs. Yes, currently I am talking about the values here in Ecuador. An appendectomy is for $800. With the robot that we currently have, that is the Da Vinci that we handle in private organizations, is at $500 and $3,000. But my vision for the future is that all technology has to come down in cost, and all that technology is going to come down in cost. It's going to be more accessible, much more accessible. The fusion between robotics and artificial intelligence is going to make it much more accessible to us. What else do we have? The subsequent home care with robotic assistance. We are already handling this a lot. We have handled it a lot, especially in geriatric places, in places that need robots that do repetitive jobs. Physical rehabilitation, inpatient care at home. What is going to help us with this? To cause a greater well-being, an independence of the patients, to be able to be much more independent, to the need to travel, to have a physical rehabilitation checked, to have their therapy in a certain place. All the robotic part is what is going to help us to be able to give that well-being to the patient. Of course, this will help us with the improvement in the recovery of patients, especially with disabilities. They must understand how difficult it is to come to patients with physical and intellectual limitations. It's very complex. But what if I can bring home health to you for the first time? That is a future, and that I share with a topic that I love, which is the architectural design part of health. Here I am going to mention a phrase that has impacted me a lot and that I believe and assume is our future, our vision for the architectural part in health. The medical architecture of the future will focus on efficiency in the patient community, incorporating technologies such as telemedicine, surgical robotics. Data management will be smart. Although large hospitals will continue to be essential for critical procedures, the trend is towards outpatient and specialized centers, reflecting more effective patient-centered medical care. For me, the future is no longer to have so many very large hospitals, huge hospitals. Although they are hospitals that have a lot of specialties, they have many good specialists. What the pandemic also teaches us is that many patients are afraid to go to a hospital for consultation, for something outpatient. Technology and robotics have made all procedures minimally invasive. What are the special or subspecialties of today? Everything that is minimally invasive, a recovery of no more than 12 to 24 hours within the institution, and all the aftercare at home, which is what you just saw on the previous slide. All care must be taken at home. This right here is going to give us as a result that all medical institutions are going to be more specialized and in smaller places with an outpatient hospitalization. I am with the conception that a patient will recover better in a familiar environment with all the appropriate measures, with the doctor's visit by teleconsultation, with the robotic part, with everything we have seen so far. It will be much better. Of course, the costs part will go hand in hand, less costs for the patient and less costs for the institutions, especially in the public part, that we have a problem. I think that most of the countries that currently manage free healthcare have that problem, which is the cost limitation. We will not need the patient to stay in the hospital for less time. It will be more effective if the procedure is minimally invasive. That for me is the future in terms of architectural health design. But now comes something key, which is the ethics and regulation part of artificial intelligence. For this I take a phrase from Paho that tells us that actions and solutions should be people-centered and not used for an end in themselves. As one of the many technologies to facilitate work in the field of public health, artificial intelligence must respect people's rights. It is indisputable. Artificial intelligence is going to support us, it's going to help us, but that's what artificial intelligence has to be, and robotics, a support, a help, and one thinks that the doctor is going to disappear. Moreover, the doctor is going to be empowered. What is it that we can do? We have to regulate. I have set some criteria such as transparency and accountability. There must be a lot of transparency, but a lot of transparency with everything we are going to do. Responsibility for our actions. Know how far the responsibility of the doctor and the team is limited. The robotic part, artificial intelligence. I have always promulgated that informed consent is the legal basis of any procedure. I don't think that will change because we have to give all the information to patients, as specific as possible about the procedure we are going to perform, and in this case, what is going to support our procedure, artificial intelligence, medicine. Human supervision needs to be regulated. The doctor has to stop a surgery in case it is required to do it, he has to start performing the surgery in case it is necessary, and limit the continuum of the surgery in the robotic part. And we must have human supervision. We can't stop doing this. How will it benefit us? With equity and accessibility, health should be accessible to everyone. It should not be accessible to those who have the economic resources. For those who are in the city, no. If we have seen the slides so far and compiled what we have talked about, it has been to have equity and accessibility in health. What is it that we need? An ethical and professional training never goes to this one too much. That's never going to be replaced. The training of our professionals. The ethical training that we must have has to be from the grassroots, from the university. That is why I allow myself to indicate what we do at the Catholic University of Cuenca. We train health professionals who not only prepare for the future, but embrace it as their present. Here we understand that change is the only constant in medicine, and that only by facing it with courage and passion for innovation, can we shape a healthier tomorrow. Our students learn not only how to heal, but how to lead and transform healthcare, building a world where health and hope flourish at every step they see together. We are creating a future of health, and there are no limits to what we can achieve. Our Catholic University of Cuenca. The vision is just to enter so that ignorance does not scare us. I always promulgate the ignorance of ignorance. We should not be afraid. We cannot be afraid of something that is present and that will be our future. Artificial intelligence, the robotic part, all that is our future, we cannot ignore, we cannot have, we can stop using. Within the Catholic University, all the adjustments that are going to be made is looking at this future. Finally, I'm going to quote a couple of phrases that I think are spectacular. Firstly, a phrase by David Hansen that tells us the future of health is in the symbiosis between artificial intelligence and human care, where machines amplify the capacity of doctors, but never replace their empathy. Another phrase that I love, Miss Hawkiku, theoretical physicist, the best successor currently for me. Stephen Hawkins, which is what tells us the real revolution in healthcare will come when our machines are not only smart, but also compassionate, when our robots not only cover, but also take care. I think that sums up a lot of what we have seen in this short dissertation. In this small talk, the future is still nothing but a future. We still haven't managed to live it as the present, but if we analyze the first sentence we had in which he told us that the future was not to use a scalpel, to avoid procedures in which there is excessive bleeding. It is the present that we are seeing now. And I think many reflections have led us to a certain future. I think that the true future that we have is to train our students, our future doctors, with this vision of having the limitations, of knowing that we have to have current rules in order to be able to form the part of artificial intelligence, because something that we should not have outside the concept. Artificial intelligence is something that we are going to nurture, it is not something that is nourished by itself. All artificial intelligence is being nourished by us. What we are going to ask for is to analyze variables, to help us with concepts a little more. Let's talk about specific for each patient. That's why I can finally finish what I started. The future of medicine, in my opinion, is the whole personalized health part, health with the patient's first and last name, the whole health approach from his consultation, his complementary examinations, his treatment, his follow-up, it has to be with the patient's first and last name. Of course, in the architectural part I think the hospitals are going to be maintained, but the vision is to be an intelligent hospital according to all the needs of the patients and the supplies we have. A hospital is going to have robotics, it is going to have artificial intelligence, a hospital has to have everything that leads to the most timely improvement of the patient, minimally invasive surgeries, a recovery in which they need no more than 12 to 24 hours inside the medical center, and that all the rest is within the family instance, which I insist must be the best care with everything that involves bringing medical technology to that family environment. With this I conclude here. I thank you very much on behalf of the Faculty of the Health and Wellbeing Unit of the Faculty of Medicine. I thank you for this presentation and I stay attentive to the orders of anything you require. Thank you very much.